IVF Real Talk.
I'm Lucy.
And I'm Yael. Welcome back, guys. Today we have Juliette Koch joining the pod.
Welcome.
Thanks, guys. Thanks for having me.
Dr. Juliette Koch is from Repromed, and she's joining us today to talk about all the different fertility treatments.
But before we jump into today's episode, we have a segment that we do that we put all of the doctors through, the ChatGPT fun facts. So we've got 3 fun facts for you that we'll do today. Dr. Koch trained at the Royal Hospital for Women's in Sydney, one of Australia's leading women's hospitals, before moving into senior fertility roles, which I don't know if this is true because we know you live in Adelaide.
Yeah, but it is true.
Okay.
So I left Adelaide after my internship back in 2000, moved to Sydney because my sister lived there and she just had an awesome life, lived in Paddington, and I fell in love with Sydney. And so I moved to Sydney and I actually, started ONG training in, I'm trying to remember what year now, I can't remember, 2003, I think, is when I started obs and gynae. And so I stayed in Sydney for a long time. I actually did all my training there and I moved back to Adelaide in 2018.
Wow.
And Paddington's also a cool place.
Oh, I love Paddington.
Yeah.
It's very cool.
I didn't actually live in Paddington. I lived in Coogee, which was cool.
Oh, that's cool.
Which is right near the hospital as well.
Yeah.
Have you ever been to that hospital?
Yeah.
You have been to that hospital
Well, I
for
used to
something
live in
I remember.
Bondi, so Randwick was kind of our local.
Is it the
main
biggest
hospital.
women's hospital in Sydney?
Yeah, there's a couple. There's RPA as well, which has got a women's hospital,
Yes.
but the Royals are very well known. Yeah.
Yeah, they do a lot of research, don't they?
Yes, and they now actually have an IVF team there as well.
Oh,
I
wow.
heard. I did
Okay.
hear about that. That's cool.
Yeah, that is cool.
Yeah.
So the next ChatGPT
Fun fact.
fun fact, Chat said she has a clinical interest in endometriosis and fertility preservation.
Is that true?
Is that correct?
Yeah, look, working at the Royal Hospital for Women in Sydney, we were really closely combined to the Sydney Children's and Prince of Wales, and we did a lot of oncology. So a lot of patients with cancer, we would do fertility preservation. And so I learnt a lot and I did a lot of clinics about that there. And I loved it. It was really rewarding and really good to have something positive in people's lives at that time where things were hard and they were worried about the future. So I definitely developed an interest in that. And endometriosis, I worked with Dr. Jason Abbott and Thierry Van Kai in Sydney, who were, led the kind of research in endometriosis. So I learnt a lot from them and I was involved in some studies on endometriosis and AMH and things. I definitely have an interest in those areas.
Chat's doing well so far.
Yeah, tick, tick, tick. And the last one is a little bit more personal, but Dr. Koch has a passion for netball and plays for the Stirling Comets. Is this true?
This is true. When I moved back to Adelaide, I wanted to join a sports team and I decided to take up netball, which was pretty hard at 45 or something. So, but I love it and we've got an awesome team and we're going for the grand final this year.
Yes, you can do it. And you were just telling us off air before we started recording, you actually have a little bit of injuries on your face. What happened?
Tell the story.
Yeah, I got a bit of a small black eye and a bit of a bung lip on the weekend. We were playing in the rain and there were a few, bit of body on body, but it's all good.
So it wasn't a ball to the face.
No,
it was
a
more
bit of body. Yeah.
I actually played netball when I was young in New Zealand growing up. I don't remember ever getting many injuries. I was young as well. We were little, so maybe it wasn't as, competitive back then.
I think.
But I loved it. I love netball.
The older women playing netball are pretty tough.
Yeah.
So it's quite physical.
But it's a good mix.
Yeah.
It's a good mix. Obviously you have quite a serious job.
Yeah.
And then, out of work.
Good outlet.
It's absolutely the thing I look forward to on the weekends.
Yeah. So we've got quite a few questions for you today. But before we get stuck into the questions, would love to hand it over to you to tell the listeners a little bit about yourself and how you ended up in the IVF space.
Yeah. So, as I said, I started my training in Sydney and I just didn't really enjoy many parts of medicine, to be honest. I found them all pretty sort of hard and sad and depressing. And then I just happened to cover somebody who was going on leave, and I had to do 2 weeks in a job that I wasn't supposed to be doing. And it was a job in obstetrics and gynae, and like I was on labour ward and helping with like deliveries and things, and it was just like a switch, like a light bulb changed. I was just like, oh my God, I love this. And it was because it was really positive. Like it wasn't death and dying, it was like birth, and it was healthy young people, and I just loved it. There was also drama, because obviously there is drama in the obstetric ward, but it was like just a really dynamic, exciting place to work, and it just totally changed everything for me. It was like I didn't enjoy going to work, and then all of a sudden I absolutely loved it. But in ONG, there's like so many different areas. There's like, you know, there's oncology, there's ultrasound, there's obstetrics, there's fertility, there's so many different areas, there's surgery. And so as a registrar, you do like all these different areas. And as a second year registrar, I got put into like an IVF section. And I can remember coming home from work and saying like to my husband, oh my God, I could never be an IVF doctor. Like it's just crazy. Like the ethical issues that they talk about and face and the complexity of it, it's way too hard and too many kind of moral decisions and things. And then here I am, like it's crazy. But the truth of it is that my mentor who I was working with was just a really inspiring person, and he really, really loved what he did. And I feel like that enthusiasm just rubbed off on me. And I just started to see all the amazing, like the wonderful side of it. And I kind of just fell in love with it. And then I started doing like a subspecialty and training and learning more and more about it.
Chat did say that actually about the subspecialty. But I feel like a lot of the doctors that come on, the IVF doctors that come on the podcast, a lot of them
just
don't plan.
Yes.
Yeah. They don't plan to go into IVF. But I really believe in the butterfly effect and how you had the cover. You started with gyno.
Yeah.
I don't know. You look back and you're like, that little tweak in your life, you had cover for 2 weeks and it led you to what you do now.
Yeah,
like, it's pretty
up
cool.
A door that you didn't
absolutely
plan.
Yeah. Before that, I was thinking of leaving medicine because I was looking at every other job. Like I was looking, maybe I should go work for a drug company, or I should do, I don't know, work in business or something. Like I just couldn't find something that I liked, and then it was just bang, it was like, it was amazing.
Well, that's what I was going to say. I feel like you've got to be a special type of person to be. And I said this to you, like to nurses and to everyone in the medical world. I couldn't do it, but I feel like IVF has this, you're creating life rather than doing all the grim stuff that a lot of other doctors are doing.
And you know what I don't see? I don't see a lot of people moving out of the industry to pursue something else. Would you say that's true?
Yes, I haven't seen anyone leave.
Yeah.
They're stuck in it.
They just retire.
But there are, that's right. And you know, one of the doctors here recently retired in her 70s.
Yeah.
So, and she found it really hard to leave because it was her life and it was so, rewarding for her.
Wow.
Yeah, that's really special.
So, Dr. Koch, we've got a lot of questions for you, all about fertility treatments today, and we've never done an episode like this, so I'm excited.
Yeah.
When I started fertility treatments, I wanted to start like something very small. Were you the same? Did you want to start like just with a pill or IUI, like the first step?
Yeah, but I started older and I knew that wasn't an option. I was like, it's either we try it naturally and it happens, or we're doing IVF. So for me, I was already warned.
But do you find a lot of your patients kind of say that to you? Like, I want to start on the very lowest step.
Yeah, look, I think I learnt very early that it doesn't really matter what I say, it's what the patient feels comfortable with. Like I know in my mind what they need, but it actually, I can say what you need, but I need to actually ask you what are you prepared to do, and what feels comfortable to start? I often find there are people that are not ready for IVF as a first step, even though it's clear to me that's what they need.
Wow.
But I can't, you have to work together. So if if that's too hard, there are stepping stones. But there are other times where someone says they come in and want to do IVF, and I'm like, oh, actually, we could just do something really basic, So
Wow.
there are times where it's the other way round, but most of the time I think it's what you said, which is I think you need IVF, but they're not ready. So there are definitely stepping stones, and it doesn't always start with IVF. There are plenty of times where I might even just recommend tracking a cycle or, working out when someone's ovulating or, doing something simple like IUI. Maybe they can't have sex, like something really basic like that, and all you need to do is put sperm in the right place and it works. So it's really very individual. And it is really important to work with where people are at and what they're prepared to do. And sometimes I'll say, like, let's just start with like baby steps and, go forward. And also I like to try and find out what people are scared of because I'll often just say, like, can you tell me if there's anything that you're afraid of or what is your biggest fear? Because once I know that, I can tailor the treatment. Like there are people that are really scared of injections or blood tests or whatever, and we can actually change things. We can use tablets now instead of some injections, and, things have changed and improved a bit. So there are ways. I think the other thing people are really scared of in IVF is their hormones.
Yep.
Like people are really frightened of what's going to happen to their brain. Like, are they going to become a witch or crazy person or whatever, like, with the hormones of IVF. So, like, if that's their fear and, like, they're actually worried they're going to, like, scream at their partner or lose their shit at work or whatever. Like, if that's what people are afraid of, there are ways that we can deal with that. So I'll say to people, like, we can change your IVF. We can, like, make your hormones crash and burn really quickly, freeze all your embryos. Then your hormones are going to go back to normal really quick. And we can put the embryos back in a completely normal cycle with no additions. Like, you can make it really patient friendly.
So maybe we can start with the least invasive fertility treatment. What would that be?
Yeah, ovulation induction is the quickest, easiest fix for people that don't have periods. So it's not for everyone. So, the idea of, I'll just take a tablet. Some people just think, maybe we can just give them a tablet and that'll get them pregnant. But if you're ovulating, that doesn't help. But if you're not ovulating, if you are having periods like every 3 months, then that's incredible because the tablet makes you ovulate and then your chance of pregnancy is much higher. So that's a really good treatment, but only for certain people. It's not for everyone, but it's really easy. It's like 5 tablets and some blood tests and maybe a trigger injection. And the pregnancy rate, if you're young, is really good. Like it's about 20 to 25% per go, and it's really cheap treatment and not invasive. So it's a really good treatment, but it's not for everyone.
With that treatment, that's something you would need to do with a fertility specialist, right? You can't just rock up to your GP and say, give me the pills.
Yeah, exactly.
Give me a script for the pills. I'll do it at home.
Yeah. And the reason for that is 2 things. One, we want to know if it works. Like if you take a tablet and you're not being monitored by the fertility nurses doing your bloods and your scans, there are 2 things that could go wrong. One is that nothing happens at all and you don't ovulate. And with us, like if you don't ovulate, we then give you more, we double the dose and increase. The other thing is that if you take the drugs and you don't monitor, you might have too many follicles and then you might be at risk of like twins and triplets and things like that. So definitely I would recommend that you take those tablets with monitoring at a fertility clinic.
Okay. No, that makes sense. And is that why back in the day, like maybe 20, 30 years ago, there was a lot of people having triplets or twins or even 4?
Look, the reason for that is actually to do with how things changed in IVF, because when IVF began in the 80s, there was no way of freezing an embryo. And so up until kind of the 90s and then late 90s, like you couldn't freeze anything. So whatever you had, you just put it in.
Wow.
And the pregnancy rates were so poor, it was like 5% per embryo, whereas now it's like 40% per embryo. The pregnancy rates were terrible. They couldn't freeze the embryos, so just everything went in. if you happen to have good embryos, you might get 3 babies, right?
That's so wild.
Now, now things are completely different. With the advent of embryo freezing, we can completely control. We can freeze 10 embryos and then put one back at a time, and you can come back 5 years later and put another one back. Like today, I put an embryo back for a 45-year-old lady that she actually made when she was like 37.
Wow. I love
That's
that. Almost 10 years ago. That's cool.
Yeah. So, and the same with like fertility preservation for patients with cancer. Like you could be 21 and you've got lymphoma or something, and you freeze eggs and then use them later. So you can freeze things now. You can freeze sperm, eggs and embryos. So it does make the treatment a lot safer because you're not putting multiple embryos in at a time.
Yeah. No, that makes a lot of sense. I've never actually understood why. I did think it was letrozole.
That does make sense. Yeah. So, we can't freeze them, so let's just put them all in, and it probably wasn't as regulated back then either. So,
that's right.
Whereas now.
Then what happened with Octomum? How did she get approved to get 8 to get 8 embryos, or maybe she had more?
She might have had some embryos split, because very occasionally, about 1% of the time, an embryo can split into 2.
Wow.
But I don't remember the story exactly of how that came about.
I'm going to look it up. Yeah.
We'll chat GPT it.
We should do a whole episode on that. It's just intriguing. We should ask her to come on the podcast. No, it might make people angry. I don't know.
It might be a bit triggering.
Yeah.
So just going back to that, what exactly is ovulation induction and what medications are most commonly used for it?
Ovulation induction just means taking a drug to make you ovulate, and it's for somebody that doesn't ovulate. And that could be a tablet or it could be an injection. So the common tablet used to be clomiphene or Clomid.
Yeah.
Now we use letrozole. And the reason for that is that there's a lower risk of twins with letrozole than Clomid.
Oh, wow.
And we're not actually aiming for twins. Like we're not aiming for twins. We're aiming for one baby at a time because we know that one baby at a time gives the best health for the baby in terms of being born at full term, being healthy. So that's what we're aiming for. So the letrozole also has less side effects. So Clomid can cause hot flushes and headaches, whereas letrozole rarely causes any side effects. So that's very much now the go-to, letrozole.
Wow, okay. Have you done both? I've done letrozole.
I've had letrozole. I haven't had Clomid.
Okay, no, me neither.
I haven't had Clomid. But I didn't realise that was the difference, and that's why letrozole is used more so. I wanted to talk about timed intercourse. Can you explain to the listeners a little bit about it and when that might be used?
Yeah, so I'm not a huge fan of timed intercourse, just as a disclaimer. And I guess that's because I think like the whole thing of like having sex when you ovulate isn't necessarily necessary or the best way to do things. Like I think I spend a lot of time trying to tell patients just have more sex over a time period rather than on the day. So what we know about sperm is the first thing is that it's really important a man ejaculates at least 2 to 3 times a week for sperm health. So if a guy is being told we're going to do timed intercourse when you're ovulating, then they might not be having sex or ejaculating outside of that, and then you've got the worst sperm like at the time when she's ovulating. So you've got a lot of sperm because if he hasn't ejaculated for a week or 10 days, you've got a huge amount of sperm, but the quality's terrible. Wow. So you actually need the guy to ejaculate regularly, and you need sperm in the body before ovulation. It takes like a while for the sperm to track up and get up through the uterus and tube to the egg. And normally what happens is there's like millions or hundreds of sperm hiding out in the tube waiting for the egg. So you actually want to be having sex before, and you want to be having it over days. You know what I mean?
Yeah.
So I don't love the idea of like timed. The only case I would do it is someone who has really irregular cycles but doesn't want to take a tablet to ovulate. So I'm doing it just to actually catch it because they are so irregular. But, you know, the tablet's so easy that it's just easier to do that. So I don't see a huge role for timed intercourse, and I think I kind of spend a lot of time suggesting not to do it.
Okay. Yeah. No, that's cool. I know there's going to be listeners listening and saying, oh my God, so how many days? What's the perfect amount of days to have sex, and what should the schedule look like What do you think about that?
Well, see, I just say have it twice a week from when your period finishes. And that way, literally that way you will always have sperm
Easy.
in a good place at the right time. And you don't have to obsess over what day you ovulate, what your temperature's doing. It doesn't matter. The sperm lasts like 5 days in your body. So the best thing is to have sex before you ovulate, and then there's sperm there.
I've heard of that before. Dr. Cooper actually said that to me. My endosurgeon, he said you should have sex before you ovulate, get some sperm up there, get things going. Well, he didn't say it like that, and he said he articulated it very different. But I've actually never heard another doctor say that before. So I love this. I love this is good. This is good information.
Juliette, do you hear some funny stories? So I got told by my GP that when I was at the start of my process and I was frustrated and like hadn't started IVF yet, and we were talking and she's like, "Oh, don't worry, at least you're having sex." And I said, "What do you mean?" And she said, "I had a couple that didn't realize they actually had to have sex." And I said, "What?" And she said, "Yeah, like they would muck around and then he wouldn't come inside, but
What?
Yeah, there are so many interesting stories.
Okay.
Can you share one with us, please?
Well, I just remember this one time where because normally I'm pretty good at talking about sex early on. It's a bit hard because you got to obviously establish rapport. It takes time. And then you're trying to talk about this really quickly. But with this one time, I just didn't ask about sex. I forgot. I just completely forgot. And it was like a 45-minute consult, and I got every other piece of information, and I was planning something. And then right at the end, I remembered that I hadn't asked, and they're like, "Oh no, we've never had sex." and I was like, "Oh my God, I have just wasted 45 minutes of time." Like, if only I had asked that when I normally do at the beginning.
So that was their diagnosis. They just hadn't had sex yet. They were probably so fertile. They probably got pregnant the next month.
Yeah. So there are, and so sometimes I have to ask, like, do you?
Isn't that wild though?
Do you ejaculate in the vagina? Like, I have to ask really specific questions sometimes.
Wow, that is crazy.
Isn't it crazy? When I heard that, I thought my GP was nuts. But like, like people don't understand the basic.
No, it's true.
Didn't we all have sex education?
Clearly,
Maybe some people haven't. I don't know.
They weren't at school that day. Across the road smoking or something. Who knows? But they just missed that.
But the other thing is, there are people who like actually have like medical reasons why they can't. Do you know what I mean?
Yes.
Yeah. So that's the other side of it. Like, there are people with like problems where, you know, I don't know if you've heard of vaginismus. It's quite a common problem where they can't physically have sex, or there are cases for guys where they can't get an erection and can't ejaculate. So there's all sorts of things. So it is super important, like, to know, like, what's happening. And there is all types of things and people. So we are used to it. We're happy to talk about it. And actually, I had this couple recently. I've had 2 cases where the problem was premature ejaculation. Do you know much about that?
A little bit.
Yeah, totally.
Yeah, so it's literally where, like, you can have sex for like 10 seconds, right? And the guy ejaculates straight away. And so what happens in those cases is they kind of just stop having sex because it's not easy for anyone, and it's stressful, and it causes emotional stress, and just, you know, it just becomes a problem.
Yeah.
And one situation, 2 situations actually, where I've seen that, there's a drug that causes you to not be able to ejaculate. And so it's like an anti-anxiety drug. And so both of these guys, like, I talked to them about their mental health and stuff, and both of them had significant anxiety and depression. And both of them, I was like, these are years apart, these cases, but they were both the same. And so I talked to them about, would you like to try an antidepressant, because it has this side effect that makes it hard to ejaculate.
Wow.
And they were like, yeah, okay, I'll give it a go. And both of them took it, and literally within 3 months, both were pregnant. Both women were pregnant.
Oh my goodness.
Just from that.
So it makes it harder, but you still will ejaculate.
Yeah, you can, but they don't prematurely. Like, it takes them, like, you know. And so they were able to feel more confident. They were able to actually have sex, and their mental health improved as well.
Yeah.
So I think that was really satisfying. Those two cases were like really, really satisfying because I didn't do anything else. That was it. Like all I did was actually prescribe that.
Wow.
And that would have changed like their whole confidence.
It changed their whole life, like in terms of their sex life, their enjoyment, their mental health, and they got pregnant naturally without anything.
And that's probably quite common too, because I always hear the ads on the radio.
Yeah.
It's probably more common than we think.
Yeah.
And on the other side of that, with someone that can't ejaculate, can IVF or fertility treatments help in that case?
Absolutely, yeah. So that's not that uncommon either, to be honest. And in cases where the guy can't ejaculate with sex, they often can ejaculate on their own, but not with the pressure of intercourse and not through sex. And so we do IUI. That's like a really good one where we can just get the sperm and put it in the right place at the right time. Yeah. I've had, good number of pregnancies with doing that.
Wow. Oh, that makes me happy.
Yeah. It's just interesting. Like I said, we went straight to IVF. So like all of this for me is new.
Yeah. There are other things. Like IVF is a kind of a go-to fix-all, but if you just get the history and try to think about possibilities, there are sometimes other simple things.
That's good.
I think it's, that's what I was going to say. I think it's important for the listeners because a lot of people think, I'm
not
seeing
getting
a fertility
pregnant
specialist. Yeah. I'm going to have to do IVF straight away. And like that's daunting and that, comes with so much anxiety. So, there are obviously all these treatments before that. And
And we know a lot of people in the community as well.
Yeah.
That it's worked, not IVF, like a step before that.
Yeah.
So
it
is nice to hear.
The other people that do like IUI, so intrauterine insemination, so it just means like preparing the sperm, washing it and spinning it, making it super fast. I say it's like giving it a Barocca. By spinning the sperm, you actually make them go really fast. And so if the guy's sperm is not moving fast, what happens is when they ejaculate in the vagina is acidic and it kills the sperm within seconds. So the sperm have to be super, super fast. They've got to get out of the vagina and into the cervix where it's safe. And so if the guy's sperm count, their sperm is not moving fast, they're just not getting past go. Like they got no hope. Because literally within like seconds of ejaculation, they're going to be dead.
Wow.
So the vagina is like this crazy kind of like, if you're not fast, you're not getting past, you're not going to make it to my egg, right? It's like the death zone. So by spinning the sperm, it makes them super fast, and then we use a little very fine catheter and we put them past the cervix up into the top of the uterus. So we're delivering the sperm closer to the egg. And if you're taking like sperm that are like maybe 10% are moving up to like 80, 90% of them are moving.
Amazing.
And so, so that can be a really good treatment in that scenario. The other case where we use a lot of insemination is for donor sperm. So, for example, like a single woman or same-sex couple that are using donor sperm, you can do donor insemination, which is simple, but it's safe.
Well, I never knew that. Did you know that? About the IUI, the spinning, and you can make the sperm faster and the
just like picturing them all having a drink of Red Bull and going for gold just to get past. Like, that's really cool.
Yeah, no, that's really – is the spinning like do you do it straight away and then you quickly okay.
Well, it's over like a period. Usually the guy gives the sample and the IUI is done an hour later.
Okay.
And so is the embryologist's job still? They're doing
Yep.
Wow.
They're doing all of that. Yep.
They've got lots of hats in there.
Yeah.
So talking about IUI, what factors determine whether someone should try IUI or move straight to IVF?
Yeah, so I guess I would frame it in like three issues. One, there's like what is medically indicated. Two, there's like what are you prepared to do? What point are you at that you can take that step? And then three, what is affordable? Right? So all of those three things have to come together. So like if I just say medically, IUI is good for people who can't have sex, for people with donor sperm, for people with nothing wrong, like plenty of eggs, tubes are working, everything's good. They're the kind of people IUI is good if the sperm motility is low. So they're the groups that IUI is good for. And then IVF is kind of everyone else. Like if the sperm is really low, you really need IVF. IUI is just not going to cut it. But then if someone's not ready, it doesn't matter what I say, right? We've got to be ready. So sometimes I'll say, look, listen, we could attempt an IUI, and if the sperm preparation's really, really poor, then we'll just cancel it. And then sometimes that's enough. Like they have to try, see that it's not good, and then they're prepared to go forward, right? So I do think it's really important to work with what people can do.
Yeah, I think that's so true. And I think you see a lot of US patients do the IUI first. And I think the reason probably is the money side of things, because IVF is so expensive in the US, and maybe they just want to try that step first or a couple of times, because obviously it is a lot cheaper than going straight to IVF.
It is.
And it's a stepping stone, like you said.
The only thing I say to people who are using it as a stepping stone is like, don't do too much of it, because as much as it's an easy starting place, anyone doing fertility treatment, it doesn't matter how hard or easy it is. It's emotionally such an investment and so sad when it doesn't work. You know, you take time off work, you have appointments, you do injections, you have blood tests, you turn up, you have procedures. Like, it doesn't matter if it doesn't cost as much, you're still massively invested. And when it fails, it's a huge heartache. And I don't want people to have multiple heartaches before they do the most successful treatment.
Yeah.
So I'm aware of the emotional, what it takes from people. And I sometimes say to them, save your emotions and your energy for something that's got a really good chance of working. Don't run out of energy doing something with low success.
That makes a lot of sense.
I've noticed in the community a lot of girls, and I did IVF in my 40s, and so I connected with a lot of older other people doing it in their 40s too. I noticed a lot that had done cycles of IVF and then were recommended to move back to IUI because the odds were a bit the same. Is that correct?
Yeah. So the situation that is like when you're over 40, or if you've got low numbers of eggs, then IVF benefits are lost, because a lot of the benefits of IVF come in with getting good numbers of eggs. Now, it's different if there's a sperm problem. If there's a sperm problem, even if you're only getting 2 eggs, you need ICSI, you need to do IVF because to get the sperm into the egg, right? But if the sperm's perfect and the only issue is the eggs, then sometimes doing IUI is just as good as IVF, because you're only going to get 2 eggs with IVF and you're only going to get 2 eggs with IUI. So why bother with all of that cost and in effort when actually you can get 2 eggs with IUI and try a cheaper treatment? So in people that are running out of eggs, I'll often go, let's go hardcore IVF first, and if it doesn't work, we'll go back to IUI.
Okay, yeah, and that's what I've seen historically happen.
I've noticed that too.
Yeah.
And that makes sense the way you've explained that.
Makes so much sense.
Yeah. I wanted to touch on the lifestyle side of things. Can you talk to us, about lifestyle changes, maybe even medication, supplements?
Oh, I don't know if you want to hear my thoughts on this, because I feel like lifestyle changes have a minimal impact.
Okay.
I feel like there's a lot of energy and effort put on it. I don't know. I see really healthy people that have problems and really unhealthy people that have no problems. Do you know what I mean? Like, as in fertility
down
wise.
the street, falling pregnant.
Yeah, the like McDonald's every day, overweight, smoking, whatever, pregnant, 5 babies, termination, whatever. Like, there is not a direct correlation between how healthy you are and how fertile you are.
Mm-hmm.
Okay, there are some basic things like, yes, you don't want to be morbidly obese, okay, but not overweight. Like, a bit overweight is not a problem. You don't want to be morbidly obese. There are things in extreme, okay? So once you're really overweight, you'll stop having periods and you're not going to get pregnant, and men stop being able to have sex when they're morbidly obese. Their estrogen levels go high, their testosterone falls into their boots, and they become infertile. So yes, there are extremes that matter. And, if you're smoking a lot, it affects your ovarian reserve and can get a significant impact on sperm and eggs in terms of the quality of the DNA. So yes, at the extremes. But if you're like, I'm looking at you and you're a normal weight and you eat normal food and you're taking your folic acid and you're not drinking like a bottle of beer every day, like, which is most people that I see, there's nothing they can really do. Like drinking green tea or whatever, it's not going to make a significant impact. Cutting out gluten and dairy, I don't. But you know what? I don't know everything either. Like I don't have all the answers. And that's why, like, I'm willing to work with it. Like you see a naturopath, see a dietitian, do everything you can, like look after yourself, look after your mental health, etc. But I'm not the one obsessing and saying you need to cut out coffee and you need to stop drinking wine and you need to do, that's not me.
Yes.
I'm like, you need to live your life and have a good time because this is a long journey and it's hard and you still need to have fun, and taking everything good out of your life because it's somehow going to make a difference. It's not true.
Yeah, and this is what Dr. Gavin said as well.
Yeah,
Remember on his
that's
episode,
right.
he's like, have a glass of wine, enjoy some sugar.
Yeah. But like you said, in moderation, like
Because it can be a long journey as well.
Yeah.
And if we're cutting out like alcohol for, years and years, like that's painful.
Yeah.
Like we want to de-stress. We want to have a glass of wine at the end of the week. So
Yeah.
I like that. But I think also like me and Yael were both very strict on our journey. I think it was a bit of sense of control.
Yeah, and that's it. That's what I was going to say. You might do things just because you want to do something and feel like you're contributing somehow.
Totally. And like I do talk to people about, like, there are some supplements out there that theoretically might help your egg quality, like things like, as you would know, antioxidants, CoQ10 and NAC and, various things, right? But I don't have any proof that they work. I understand the concept of how they might work and I'll talk about them, but I'm not going to like outright prescribe them, if that makes sense.
What about holistic, like acupuncture? What's your thoughts on that?
Look, I think, again, with that, like, I'm like, do anything that helps you. Like, if acupuncture, to me, I can imagine that being helpful, like just for me mentally. Like, I think the idea of lying down and people doing something to you, it just feels kind of like nice. I don't know. I think it has benefits, and, taking a supplement that you feel like it's going to improve your egg quality, like these things might have benefits. And if it just helps you to get through and do stuff, I'm all for that. But I'm not going to kind of sit there and say like, you have to do this.
Yeah, I respect that.
Yeah,
I like
too.
that.
Yeah. And it's nice to get different opinions too.
Yeah, I agree.
Yeah. So moving on to IVF, can you tell us the difference between natural cycle IVF and a stimulated IVF?
In Australia, no one really does natural cycle IVF. Like, we do natural cycle frozen transfers, like a lot of them. And in fact, these days we do most of our transfers are actually frozen transfers, not fresh. And so that allows it to be done in a completely natural environment, which I love and is really good for patients. And there's like minimum like side effects or hormone changes. So, but an IVF cycle by definition is a stimulated, you're stimulating the ovaries to get more eggs than one. So you take injections for like 10 to 12 days to grow the little follicles in the ovary, and then you get those eggs out and put them with sperm, either standard insemination where you just put sperm on top of the eggs in a dish, or ICSI where you actually pick up one sperm and inject it into each egg, one sperm per egg. We use ICSI when there's a really low sperm count because we know that we won't have enough sperm to fertilize. See, most sperm are no good, right? So you actually need millions and millions per egg. So whereas with ICSI, you just need one sperm per egg, and you try and pick a sperm that's moving and you put that into the egg. And there's a couple of different techniques with ICSI now. The standard ICSI technique is using like a beveled sharp needle that injects the sperm into the egg. And there's a new technique called piezo, which actually comes out of Japan. And it's a technique where you use a flat needle and you actually vibrate the sperm in rather than piercing the egg. And it's a little bit more gentle on the egg. So that's another technique that we're using in some people.
So we're not hitting the sperm on the head like we saw that went viral.
Oh yeah, there was a real from was it an embryologist?
Yeah, I think an embryologist put it up, a reel that went round.
Yeah, that she was knocking the sperm with the needle, just to make it a little bit less slow.
A bit drunk.
Yeah.
Drunk like.
Yeah, they strike it on the tail and they suck it up into the needle. They still do that with piezo, but it's the same technique to pick up the sperm, but it's the way the sperm goes into the egg that's different.
Okay, that's cool. Yeah. And that's what Professor Deidre
she
was involved in.
Yeah, that's right. She talked about her involvement in piezo.
Yes. Which is so impressive.
Yeah, she bought it in.
Wow.
Really cool.
That's so cool. You doctors are just, you blow my mind.
Amazing.
I wanted to talk about the Hycosi test. We both had it, right?
Yep.
We hear that it can really assist with fertility. Like, I remember when I got it done, the doctor said to me, we'll see you back in a few months for your pregnancy ultrasound. Like, what can you talk to us a little bit about it? I mean, I think a lot of patients are also scared to do it because of the pain.
Yeah. So, yeah, it can be a little bit painful, and we do recommend taking pain relief before. What we're doing is putting a really tiny little tube that's about 1 millimeter in diameter into the cervix, and then we're putting saline, like agitated bubbly saline, into the uterus, and we're seeing it come out through the tube under ultrasound guidance. And the uterus is actually like a closed space. All the pictures of the uterus, you imagine that it's like got this cavity, but it's actually a completely closed space. And so when you do a Hycosi, you put fluid in and it makes the uterus contract against it and causes cramps. So that's why it's a little bit painful.
So would it be like a contraction?
Yeah.
Like a labour contraction?
Yeah, a little bit. Yeah.
Just for like a second, right?
Yeah.
Because I remember feeling pain, but it just felt like endo pain for me. But you were under when you had yours done.
Yeah, I was under.
Yeah. So it's just that cramping. And the other thing is, like, if your tubes are open, then the fluid comes straight through, right? So it's not very bad. Like, there's not much cramping at all. But imagine if that space is blocked. If the tube is blocked, then you're pushing against blockage. That's when it's actually painful.
Wow.
Okay.
So when we actually find there are blocked tubes, that's when we're like, there's something really going on here.
And does it help? Because what I was told was it really helps your chances to conceive naturally after this test, up to like, I think 50%. Don't quote me on that.
Yeah, there is some data showing an improved natural pregnancy rate after, and it's there's a bit more data on like Lepiodol. Have you heard of that? It's the poppy seed oil.
A little bit.
Yes.
Yeah, so it's a contrast agent, and it's like a iodine-based water-soluble agent that you could put in, but it's got poppy seed in it. And it was used back in the 80s when these tests were done with X-ray. So in the past, you did X-ray. So you had to have an agent that you could see on an X-ray. And the Lepiodol would come up on the X-ray. And so they did studies, and they found that women who had endometriosis were more likely to get pregnant. And so over time, more and more big studies were done and showed that in women with endometriosis, a Lepiodol flush improves the chance of pregnancy. We don't really know why. Yeah, we don't know why, but we think that it has, like, the iodine content is like an anti-inflammatory kind of effect. And as you know, endometriosis is thought to be like a kind of an inflammatory environment where there's like cytokines and things that damage the egg and the sperm and the uterus. So this is thought to have an anti-inflammatory kind of effect, and maybe that's how it improves. But there are definitely people who get pregnant after.
Okay, that's good to know. So would you think it's worth getting done? Would you recommend every patient or just some to get this test done?
Yeah, when do you step in and recommend that?
Because my GP recommended this test to me.
Yeah. I recommend it for almost everyone. Like, it's such an important test, and it's not just got to like helps people, but it gives us so much information about what's going on. Yeah.
So you've touched on both IVF and ICSI, but can you go into a bit more detail about the differences?
What we mean by IVF, in vitro fertilization, there's like two types. There's standard insemination or ICSI. So standard insemination is where we wash and spin the sperm and get the most motile sperm and lay 50,000 sperm on top of 4 eggs in a drop of oil in a dish, and however many dishes for how many eggs. So 50,000 sperm on top of 4 eggs. And then we wait. And so then the next day we look at them and see if they fertilized. Now, in 5% of couples who have absolutely nothing wrong, like unexplained infertility, nothing wrong, all the tests are completely normal, when we put the sperm on the eggs like that in the dish, we find that they did not fertilize. So the sperm didn't bind to the egg, the sperm didn't get into the egg, and it didn't activate the egg. And so in those cases, we can't rescue the situation. We have to start the whole process again, and then next time we have to do ICSI. But we would start with ICSI in a couple where there's a really low sperm count because there's not enough sperm to get that many sperm on the eggs. So we would actually start with ICSI. And that involves taking the cells off the egg, checking that the egg's mature, and then injecting the sperm into the egg, and then the next day seeing if it fertilized. And fertilization rate with ICSI is about 70%. Like 70% of eggs fertilize with ICSI, and it's about 65% with the more natural method.
Okay.
So not every egg fertilizes, no matter what you do.
Yeah.
So if ICSI is 70% and IVF is 65%, why doesn't every patient just get recommended to do ICSI?
Because ICSI is more stressful for the egg. And so first of all, you have to take all the supporting cells from the egg off, whereas in standard insemination, all the supporting cells, the cumulus cells that are supporting the egg are still there. But you have to take them off when you do ICSI. And also the process of injecting the sperm into the egg can break the egg. You can get lysis. And so there are cases where you are way better off doing less. And this is something not everybody realizes, but sometimes less is more.
No, that makes sense.
And I've heard that. Like, you always try and do it as close to natural as possible. So that makes sense.
Yeah.
I've never heard of lysis.
No, me neither.
What is
I've heard
lysis?
the
I'm
breaking of the
curious.
egg, though.
Yeah.
Lysis just means breakage of the egg. So if you, like, let's say you got 12 eggs and 10 of those eggs were mature and injected with sperm, and then the next day the lab ring you and say 3 fertilized, and you're like, oh my God, 3 out of 10. What you not want to know is what happened to the rest. So did they break or did they just not fertilize? Like, what actually happened? Because that then determines your next moment of technique. Like, if you got a lot of lysis, then you want to try the more gentle ICSI, or maybe you go back and just start at the beginning and just lay them on the eggs and don't inject them at all.
Or could you do a mix of ICSI?
That's what I was going to ask. Do you ever do half-half for your patients?
We do. Yeah. We do that a lot, yeah.
And
it's called a split insemination.
What do you normally see results-wise with that? Do you see a mix of results?
Yeah, you do. Like, I've got all things. Like, I've seen everything. Like, I've seen cases where, standard insemination, just nothing happens and ICSI is the way they get a baby. And I've seen cases where ICSI is so bad for their eggs, and when I do nothing, their eggs are fine. I've seen every different thing happen. And so that's why there's no necessarily clear path. It's like you start with something, you talk about all the options, why you're choosing it, but you're also aware of things that could go wrong, and then you change.
Sounds very unpredictable.
Yeah. And I mean, I think when you compare cycle to cycle.
Yeah, that's true. It can be so different. I had 0 fertilization to 100% fertilization. Yeah. So you're right. I feel like it can be so different.
And then all 4 cycles for me were just, you can do the same protocol and still get the same outcome. So it's really hard, which I could imagine would be really hard for you guys to determine what's the next best step. So
it'll be like being a detective at times.
It totally feels like that. It's totally like that. For me, it's like that. Yeah. And then like the lab really help because they give us like advice on what to do. So the embryologist is such an important part.
Yeah. What fertility treatments do you think are overlooked? And what's your favourite?
I think something that's overlooked is probably the fact that people are leaving it really late to have kids, and there is this sense that IVF, and it does work for some people, but there are a significant number of people where it doesn't work. And I think a lot of people are actually having to use donor egg to have a baby, and it's not talked about much. I feel like it's probably not talked about enough, because I feel like there are a lot of my patients who over the years have done multiple IVF cycles, nothing's worked. And they actually achieve a pregnancy with donor egg, and it's very successful. And I feel like it's not talked about enough. It is really expensive. We don't have many donor eggs in Australia because it's not part of our culture to donate. Whereas in America, like, everybody donates. They donate sperm, they donate eggs, they donate blood, they donate bone marrow. Like, it's part of the culture. In Australia, it's not part of our culture to donate, and it's not talked about much. And I feel like we need egg banks in Australia. Like, why do we have to go to the Ukraine to get eggs?
Yeah.
Why don't we have egg banks in Australia? I know there are people out there that would be willing to donate, but it's just not talked about. And people who have a baby with donor egg don't tell anyone that it was donor egg.
Yeah.
There's a sense of shame, which I get, I understand that, but I don't want that to be the case. And I talk to people about saying, like, you got to move past the shame and say how incredible it is.
Yeah.
Like, what an incredible gift and an amazing thing that could happen, And I want your child to grow up knowing that that was an incredible gift and not feeling any of your shame because, that sadness, it's got to it's a really tough process, and sometimes it takes years for me to counsel someone to donor egg, because of getting through the sadness and the grief towards the positive and the joy and the beauty of it, and celebrating it rather than seeing it as a terrible thing. So I feel like that's a story that's not talked about enough.
Yeah, we know people personally that have gone through the donor egg that haven't even told their parents.
Yeah, that's right.
And they're proud of it themselves. They are. I think it's more
the shame.
Their parents and the judgment, the stigma, the culture. So it makes it really hard. And I think IVF is slowly getting more talked about, more awareness. People have slowly started to talk about it more. But I feel like that's fallen behind.
It has.
And I don't know, do you think it will catch up one day?
I hope so, but it does take some brave people to start talking about it. In the past, like kids that were conceived through donor sperm, which was anonymous, they grew up and then they rallied the government and they changed the laws in Australia. Like, people have to be brave to, like, talk about things and change things.
Yeah.
And I don't know, like, we need people to be brave. Like, I try to connect patients as well. Like, I have patients where I'm like, I know they're struggling with this decision. And I say to them, like, I've got patients who've had a baby with donor egg and are really happy. And I'm like, will you talk to someone else for me? Like, and so recently I've, like, connected a few people and I just they're like, yes, no problem. So I give their email and I'm like, this is someone who's been through the journey, like 10 IVF cycles without success, donor egg baby. Like, talk to someone who's been through it, understand, like, you can have a happy life, like, you can have the family that you want, but you need to be open and people need to talk. And I want to celebrate it. Like, it's an incredible thing. It's not something to be ashamed of.
Yeah, absolutely. And we've had a few ladies come on and shared their donor journey, and they all talk about, like, once they have their little bub, how they don't even think about it, but they also all say, if you know anyone, I'm open, like, happy to talk to, happy to guide them. And I think they've got their own little community and they do really support anyone.
Do you know what's also really hard though is there are communities in Australia that it's not even an option. Donor egg or sperm is culturally unacceptable. There are definitely some really significant issues occurring and, like, for example, families where there's shame, like, put from generation down, like, there's that stuff going on.
And you see that just by doing IVF, like, even that can,
But it makes it hard because adoption is so incredibly hard in Australia.
It's impossible.
So, like, a lot of us don't have that option to go to adoption. So this is our way to parenthood.
That's right. Exactly.
But it's also, that's exactly right. It's not talked about enough. And so the older generation think adoption
just adopt.
Because it's what used to be.
But they don't understand it's very different. Like it's not easy
and that's because, like, in Australia, the whole law and culture is now that a child should stay with somebody that is related to the family. So the adoption just doesn't even happen.
Yeah.
Like, they'll find an aunt and uncle, a great, somebody within the family to care for, which is probably the right thing.
Yeah.
But it does mean that there are literally, 2 adoptions a year in New South Wales. Like, it's extremely rare.
It's really sad.
Yeah, it is sad. It is sad.
Because we both have someone in our family that's been adopted too. I have a great aunt.
Yeah, my mother-in-law was adopted. Yeah, and her sister. So they were both adopted. So
The other thing, I mean, the reason why also adoption is not that common now is because if you don't want to, like, there's more access to options if you don't want to be pregnant as well, right? So, like, women have choices and stuff. So the whole babies born out of wedlock in the 60s, 70s, things have changed now. So there are definitely adoptions, just not, it's actually not something I even talk to my patients about because it's not a realistic option.
yeah.
Did you ever, in your earlier career?
Talk about adoption?
Yeah.
Yeah, I did occasionally. I've had one case, one successful family where I helped them through fostering to adopt. So they fostered a baby and they ended up adopting her and that was in Adelaide. But that's literally one in like 8 years.
Wow.
Yeah. And in New South Wales, I didn't have any cases.
Wow.
Yeah, it's huge. So lastly, what advice do you have for someone who's not ready to jump into IVF but still needs help?
My advice is like, come and chat, come and do some tests, just get some basic things looked at. It doesn't have to be big. You can come chat and come back in a year. Like, sometimes it's just reassurance. Sometimes it's knowing your choices. I think also, like, if you don't connect with your doctor, see another doctor. Like, it's important to like connect, to like your doctor and get on and have like trust in each other and things. So I think if you see someone and it doesn't gel, don't give up. Like, go see someone else, talk to your friends. Like, yeah, I just think start somewhere.
What about we find a lot of people message us and they say, I'm ready to see a fertility specialist, but my husband or my partner, he's just so against it. He wants nothing to do with it. He's not ready. Do you get that a lot as well?
I do actually, yeah. And I really try to chat to the women and reassure them about how I would talk to their partner, like, and my approach, because, yeah, they don't want a bar of it, right? But I get that. And so sometimes it'll just be a phone call. Like, I'll say, can we just, like, let's just have a phone call with him. Let me and him have a chat on the phone. And it can just start as just a really basic thing. Yeah, I think it is important to be able to talk and to be able to know what your choices are and just to be able to talk to someone that's, just going to be honest and support you. And if he doesn't want to be involved, that's okay as well.
Yeah. If there's someone listening right now and they want to reach out to you, where can they best find you?
Just through Repromed in Adelaide. Yeah, just bring up, we have lovely people who can help you to see whoever you want to see. They'll talk to you on the phone and tell you what to do and organise an appointment, or often we'll ask you to do a couple of tests like AMH or a sperm test first so that we've got good information to talk to. So you're not having multiple appointments. If you're from the country as well, like we're setting up a situation for people from the country who can come and do everything in one day, which is really cool. Like, they can come in the morning, do like a sperm test, an ultrasound and AMH, and then go out for lunch and then come back in the afternoon, have all the results and meet the doctor.
Oh, awesome.
Yeah. So things like that, like, we're just trying to make it easy for people. Zoom is also really good. Like, it's good though to meet face to face once, and then Zoom is fine. Phone calls we do a lot. Like, if you're at work, why drive all the way here? Like, it's just a 5-minute call to tell you your AMH or whatever. So we try to make it as easy as we can.
Oh, I love that.
That's cool. And we'll add everything.
We'll link everything in the show notes as well. But thank you so much for joining us today, Dr. Koch. I feel like I've learned a lot. I always learn so much. But I thought this episode, I feel like I know a little bit about IUI and ovulation induction. But no, you blew my mind.
Yeah, exactly. I knew I was going to learn a bit because,
I done a lot of research on my journey before going to IVF. I'd done so much research. And then when I got there, I was like, yes, is it IUI? Is it ovulation induction? What are we doing? And she's like, IVF. And I'm like, no.
Whereas I was the opposite. I had no research and I was just like, go do IVF.
Yeah.
Okay.
Everyone's so different. And that's the thing. Like, we're all really different. We bring lots of different things to it, but it's what makes it interesting. And hopefully, we can help, hopefully.
Yeah, absolutely.
Thank you so much. I think that's a wrap on this week's episode. Thank you, Dr. Koch.
Thanks for having me.
Thank you, everyone. And we'll see you next week. Bye, guys.